examination. So pretty soon we're gonna have you guys start setting up your trays. One of the reasons we set up trays is to have all the items that we need to make sure we can perform our exams. Another thing about having your trays set up is if you ever get lost during the whole man, you're like, man, I'm kind of like flustered. What should I do next? Take a breather, step back, think, reflect yourself, look at your tray. 9 times out of 10, if you look at your tools and you see there's something on there that you haven't used, that's gonna tell you, oh, I forgot to do this or I need to do that, right? Reflex hammer, 2x2s. There's a couple of reasons why we use 2x2s. We use it for the HEENT exam, right? We use it for light touch, sharp dough, both tuning forks, right? Everything that you put on your tray should be utilized. Sense, right? So set up your trays. We'll probably have you guys start setting up those trays. Yeah, by next week, like Monday, right? Because after cardio, they should have everything they need for stethoscope. So yeah, you'll start setting your trays on Monday. Okay, so HEENT exam. All right, I'm gonna start with the ears. Right?
No.
What?
No, where am I starting?
Head.
Head, right?
Wash your
HEENT, a
hands.
full HEENT. Yes, wash your hands.
Wash your hands.
So let's wash hands. Let's get some. Introduce myself.
It's my sensei.
I'm gonna go ahead and wash my hands or sanitize, don the appropriate PPE. Good morning. I'm Staff Sergeant Hunter. I'm an IDMT student. We perform an exam today. Visual acuity check, and then look at the head. First thing you want to do is actually examine the head, take a quick look, right? And then look at everything, make sure it's normal cephalic. There's nothing that looks like there's any gross deformities. And then you want to go ahead and part the hair. Oh, I'm so sorry.
This is not palpation, this is still inspection.
I'm sorry, this is still inspection. Yeah, you're gonna go ahead and part the hair, taking a look. So I'm looking for any scaling, right? Could be seborrheic dermatitis, any nevi, moles, things like that. It's gonna be a little bit more difficult with the ladies, so ladies, make sure you have your hair down that day. All right, and everything. I don't see any infestations. And then we go to our palpation.
Do you want me to read the room?
Yes, read. I'm sorry, yes. Go ahead.
Normal cephalic with even hair distribution, no masses, lesions, swelling, scaling, or discoloration.
Bless you. And then we're gonna go ahead into palpation. Now I've done that. Go ahead, palpate the head. Coming down to make sure we get behind that area. We're gonna put those tuning forks at the mastoids, make sure we palpate those. And then
Hair texture is normal without infestation. Scalp and mastoid are non-tender.
okay. Then what's next?
Inspect and palpate. Perform range of motion of KMJ.
How many fingers we're gonna use?
2 or 3.
2, right? At least 2 minimum, 3, right? So you go ahead and kind of feel. It should be your approximately where his TMJ is at. Say I. Actually, close. Yes, right in there. Say I one more time. Open halfway. Move your jaw side to side. Move it back and forward. Very good.
TMJ not tender and without swelling. No pain, popping, or locking with range of motion.
Okay. Then what's next?
Cranial nerve number 5.
Cranial nerve number 5. So you go ahead and remember placing hands because we're testing the temporales and the maxillars, right? So hands, I usually put my hands up high, bite, and then bite. Very good.
Cranial nerve number 5 intact.
And you should feel the muscles literally pulse and clench down on your hands. So I usually do up and then overlap here at the bottom. Okay. Next.
Cranial number 7.
Cranial number 7. So this, we're checking the facial, right? So this is all our facial movements. Okay, so I want you to smile, show your teeth, puff out your teeth. Very good. Close your, raise your eyebrows, close your eyes, close them really tight. Don't let me open. Close them really, really tight. Okay.
I think there's a frown.
There's a frown.
That's it. For, I missed the frown. Thank you for catching. And then frown.
And is there
Very
a
good.
difference between like smile and then smile with your teeth?
Yeah, so smile, and then that's the same motion. Then smile, show your teeth.
Cranial nerve number 7 intact.
What's next?
The eyes.
The eyes. Okay. So with the eyes, what's the first box of the say? Inspect the conjunctiva. So right.
Inspect eyes, brows, lashes, and limbs.
So sorry, excuse me. Eyebrows, lashes, and limbs. So yes, go ahead, take a look at the eyebrows, look at the lashes, look for anything that step off. We talked about this yesterday, right? So if he had one eyebrow that was like this, maybe half of it was cut off, I would think there might be something wrong with his thyroid, right? But his eyes look very symmetrical. There's no scaling in there. His eyes just look fine too. Then I would say
Notosis, exophthalmos, edema, periorbital discoloration, or skin lesions.
okay.
Now you're gonna inspect and palpate lacrimal duct.
Okay. Here you want to go ahead and have your eyes open, and then what you want to do is start from here, have them open as much as possible, and then you want to go ahead and push up to milk up. If you feel like it's a little too hard for you to get your thumbs in there, you can use your index fingers and push up as well, but I recommend using the thumbs to go ahead and milk up.
No,
No.
swelling or regurgitation.
Regurgitation, yes. Next.
Evaluate visual fields by confrontation.
Wait, what?
Is the conjunctiva not on there? I feel like we're missing something.
Oh.
The conjunctiva is further down?
visual fields.
Yeah.
14
is the
next
fourth.
one.
Before the conjunctiva, okay. That's what I'm trying to throw. I first forget the conjunctiva first. Maybe we could do it out of order that one time. Okay, so visual field. So once again, you want to be as close as possible. About 2 feet. And then we're gonna close one eye. So I'm gonna say, sir, go ahead and close your left eye. And I'm gonna close my right eye. And then I'm gonna wiggle my fingers. When they come into your field of view, tell me when you can see them. Just say now.
No.
Very good. And I would say, oh, sorry, then we would swap. Excuse me, swap.
No.
Visual fields are full and equal to examiner.
Next.
Now you're gonna check the extraocular movement and lid lag. 6 extreme cardinal fields of gaze.
Okay. So this is our H. So, all right, sorry. With only your eyes only, follow my finger, okay? What's wrong with this?
You didn't go far enough.
Correct. So you want to see all the eyes, right? So you see no whites there. Up. Down. Very good.
Okay. ELM's intact and equal without nystagmus, no lid lag.
No lid lag. So make sure when you come back to your center position, you go up really quick and come down really quick, right? And lid lag would be, what would be a positive sign of lid lag?
You see whites.
If you see right, that means the lid is lagging behind the eyes. Correct, the iris. Okay, very good.
Alright, next inspect conjunctiva and sclera.
So weird. Okay, so go ahead and take your eye like this.
Pupillary reaction.
Alright, yeah, assess for pupillary reaction to convergence accommodations.
Near far. Near far.
Oh, near far. Okay.
Higher.
Okay, it's a lot. So near far. So about 10 centimeters from above, right? So probably about right there. So I want you to go ahead and you're gonna fixate on this pin for me. And then I want you to look over my shoulder. Like right here, look over my shoulder. Okay. Look at the pin, look at my shoulder, look at the pin, and look at over my shoulder.
Eyes converge equally and pupils constrict with no focus, near focus.
Okay.
And now you're gonna inspect the conjunctiva and sclera.
So far. I don't know why I'm having a hard time breaking my head so far. Okay, so then, sir, I want you to go ahead and take your fingers, open your eyes like so. And I recommend just grabbing a light for this. That way you can already have it in your hand because the light, you're going to need that next. So go ahead and look down, look up, look left, look right. Okay.
Now, lesions, injection, icterus, foreign bodies, or edema. Now you're gonna inspect the iris and pupillary reaction to light, direct and consensual.
To direct and consensual. Okay, so actually I'll put the light back up. See, I told you that's why. Had to keep it. Okay, so sir, go ahead and just kind of look over my shoulder, kind of gaze, don't lock on anything. So get close enough so you can see the pupil. You can do it both on each side. Okay.
Pupils are equal, round, and reactive to light bilaterally. Now you're gonna evaluate position and alignment of eyes, cover, uncover, and Hirschberg.
Okay, so with the cover uncover, this is where a nice little. So, alignment wise, so stand in front of them. All right, so just kind of look at this lettuce right here, this hair that's not gelled down. Kind of like come down a little bit further. Look here. Look further here. Look down a little bit more. Look down a little bit more. There you go. Perfect. So we'll do that. Now here, I want you to take this. And I take you to cover your eye. I want you to cover one eye. Just cover your eye like so. Don't put too much pressure on it. But just cover it and let go. Okay, then we're gonna switch hands. All right. Go. Cover. Uncover. Cover the other side. A bit more there. Uncover.
No strabismus observed.
No strabismus.
Strabismus.
In his eyes, he doesn't have any strabismus. He was locked on. Okay.
What are we looking for right there?
So that's when, remember, we talked about the lazy eyes
Okay.
not being in alignment, right? So if he's got
That's the one that will pop
strabismus
back
and
in
we
place.
cover it, right? It's once it gets full to the dark, it's just gonna get kind of lazy. It's gonna pop back into place, no light.
Okay.
Now you're gonna check the anterior chamber depth.
Okay, so that's the crescent shadow. Actually, I have this one better. So I can get closer. What's wrong with this?
Too
Too far. I want you guys to be just like this.
You're supposed to see the light on the other side.
Yes.
Okay.
Then
When you see
look
a
straight
shadow,
ahead.
there's a problem.
I can see the browns of his eyes. Good.
No crescent shadow. Now you're gonna inspect for red reflex.
This the front. We're in our frontoscopic exam.
Mm-hmm.
All right. So, I ain't taking again. I'm sorry, I have coffee breath. Okay. So we're gonna get close. Remember, I said about 1.5, about maybe a foot out initially, and then we're gonna come in, right? So, opposite hand. I'm gonna hold up his eyebrow. So make sure I have. Sorry, I want you to look straight ahead. Don't lock on anything. Just look straight ahead. I'm gonna look. Okay. Red reflex is present, and then I'm gonna go in. Look into the light. Look into the light. Good.
Alright, and then the readout.
No red reflex present. Stop to each eye. You wanna say that?
No red reflex?
Interior
There is a
chamber
red
lens.
reflex.
Oh, it should be red reflex. That's
red
bad.
reflex present.
Red reflex present, cornea anterior chamber lens, vitreous are clear without opaque,
Yeah.
haze and curvature, disclosed yellow margin strap. Cut this ratio is 1:2, A ratio is 2:3, that nigga spasms, and image activates, no lesions on macular.
Okay, go ahead and put the same arm right here. So same thing, we're gonna switch sides.
Each eye.
Remember, left eye to left eye, right eye to right eye. Okay. Once again,
How far
Sorry,
away are
what's
we
your-
holding the light with the red reflex again?
about 12, like no, probably like 12 inches.
Arm's length. Okay.
I go like 12 inches. I get too close. I'm already gonna
Okay.
come in. So we're close enough, but you could be arm's length away, but like 12 inches. So, oh, that's right. Okay, what would I say?
Red reflex present, and then corneal anterior chamber lens and vitreous are clear without opacities, haze, or
Encroachment.
encroachments. And then this color is
Yellow. Orange. His is actually yellow orange.
margins are sharp, and cut to disc ratio is 1:2. AV ratio is 2:3 without nickening or spasms. No hemorrhages or exudates. No lesions on macula.
So for lesions on the macula, at that point you ask the patient to look directly into the light, and that brings the macula into your vision. So that is an important part. So you can do all the verbiage, but if you never tell your patient to look into the light, you're gonna get a U for not
Correct.
looking at the macula.
So if you want, you can go ahead now. Certain classes they like to say it as they go in, but if you start trying to memorize, now you got that light shining in their eye, right? So if you're gonna do that, make sure you have your verbiage down so you can go with that light is gonna be bothering your patients, right? And then you have them looking at this light. More than likely, you'll be able to see a little bit of the macula. It's gonna kind of come into motion, but you're not gonna be able to see it. Really, you need a dilated exam to see those. But we teach you guys the verbiage. Yes, sir.
Have to take place or just all the verbiage for each eye?
Yes,
Okay,
because each eye could be different.
okay.
Yes, so report it out twice is best. If they are both normal and you wanna try to do all the verbiage at the end, after doing both eyes, you limit the amount of opportunity you have of getting the verbiage right. So,
Correct.
let's say if you forget to say, no nicking and spasmings on the first eye, but you catch it on the second eye, you can actually still get credit.
Say it twice.
Yeah, you be like, no nicking and spasm on the other eye as well. Okay. What's next?
Next is the ears. You can inspect, palpate, auricles, and tragus.
All right, so we're gonna take a look at the ears. Make sure you look at both ears and step just a little bit behind the ears to take a look behind them. All right, so you do this thing. Okay.
Now lesions or discolorations, non-tender.
All right, good. So I was gonna say it's gonna palpate on the auricles. All right, and the traguses. All right. And what else am I supposed to palpate? Auricles, tragus, and what else?
Just auricles and
Oh,
tragus.
okay. Okay, continue.
Inspect external auditory canals.
No, right?
No.
Otoscope.
Yes.
Get the biggest one, biggest speculum you can find. Okay. There, we talked about bracing, right? How are we gonna pull our ear? Up and out. Okay, so if you're right hand dominant, you're coming to the left ear. Once again, you can either switch. Oh, let me see that. Then that's secure. Make sure you have your speculum secure. Underneath your arm, please. So you want to go ahead and brave it up and out. Make sure you have multiple points of contact, at least 2 solid points of contact, and be up on this this cheek and not on this jaw, because the jaw is movable. If that doesn't work for you, you could try this way for bracing and just use your hand like so and brace actually against his head, which I would recommend if you're not ambidextrous. So up and out. And I'm gonna look. External auditory canal is
No swelling, obstruction, or redness.
okay. TMs are
Pearly, gray, and translucent. Light reflexes and
Anterior.
anterior and inferior.
You can make sure you get it straight, yeah. So this would be like 7 o'clock.
quadrant, or tensor, or
Easier for the other one.
handle of malleus visualis, and distorted, no fluid behind TM.
And then, do you have them Valsalva? Is that why the
Mhm.
team is mobile?
So, sir, I want you to go ahead and clear your ears. When I tell you to, I want you to go ahead and pinch your nose, keep your mouth open, and just blow. Okay, on 3. 1, 2, 3.
TM is mobile.
And then you do the same thing on the opposite side.
Can we just have them rock their jaws?
Can you have them lock their jaws?
Rock their jaws.
Rock their jaws.
Yeah.
Like yawning
To
motion.
do that, no.
No.
Blow,
It's
yes,
gotta
no.
be a blow.
We want them outside.
Sometimes it's too subtle to notice on
Mhm.
examination. So
Okay.
do something a little bit more.
A lot easier on this side because it's
Easier to
naturally
see.
right-handed. Okay, external auditory canal,
Now,
TM, and then you say all your verbiage, and then go ahead and cover your nose and blow on 3. 1, 2, 3. Stop. TMs are mobile, right? In this case, yours wasn't.
You did,
Any questions on that? Bracing wise, I know I showed you guys a couple.
speculum on this
If
side.
you can get this, I think it's harder with this because they're on the wall, so the cord is fighting you. The actual, the other ones that we give you, the handles are a little bit heavier, so you'll be closer to the skull. You can rest your hands that. You can put the 2 fingers or your 2 DIPs on the back of the head. You need at least 2 points of solid contact. At least for me, I can speak on this side. It's a lot easier because I'm already right-handed. I can go ahead and I can brace easily onto his cheek. Sorry, Does that make sense?
So on the right side.
You can also wrap the cord like
Yeah, I have multiple fingers like this. On the left side, it's hard for me. So now I was doing it, I had it like fingers more spread out because it's just weird. This is fighting. But at least 2 solid contacts on the skull, on the cheek. You must have that, okay? Some people I have seen where it's kind of like, they're on the neck, but see, that's on the jaw, and we don't want that.
Can you do that again, please? Thanks.
They try to do it like this, but this is on the jaw. You can't do it that way. So you need to be up here or somewhere on the scalp, on the skull.
Okay. Thank you.
What's next?
the whisper.
All right, so I'm gonna whisper some words to you. I want you to cover first your left ear. I'm gonna whisper in your right ear. Tell me what and repeat what you hear, okay? baseball.
Faithful.
Oh my
Oh, I didn't know what you wanted me to repeat.
Whisper Texas.
Go ahead and
Negative.
switch.
Football.
Cranial nerve 8 is intact. Barely. Barely.
I was scared for a second. Like,
The Weber
can you hear it?
test.
Can you hear it?
All right, the Weber test. Okay, so we're gonna pluck our fork and we're gonna place it at the top of the scalp at the apex, right? And then we want to see if you can hear it in both ears. Okay, sir, I want to pluck this and put it on top of your head. Tell me if you hear it good in both ears or whichever ear you hear it better in. Okay.
Now it is resting on his skull,
Yes.
so it does conduct along the bone.
Okay, good. Weber,
Weber's equal bilateral.
bilaterally. And then now we're gonna do the Rene.
Yeah.
So here we go. This is the one we put on the mastoid. So we're gonna pluck. Well, actually, I'm gonna explain something first. So I'm gonna go ahead and pluck the fork, put it behind your ear on your bone, dampen it down. When you can't hear it anymore, tell me. I'm gonna put it in front of your ear. Let me know if you can still hear it. Okay?
Bless you.
Bless you. So then this is the. Go ahead and turn this way so everybody can see. Well, they actually rotate just a little bit. There we go. Perfect. This is the spot, the mastoid we're looking for. Okay. I mean, you can't hear it anymore.
Can't hear it.
Can you still hear it? Confirmed. To the opposite side.
Same thing.
Can't hear it.
Can you still hear it?
Yeah.
Confirmed.
Renee is.
Air conduction.
Renee is.
Renee is AC greater than BC bilaterally, which stands for air conduction is greater than bone conduction bilaterally.
You
No.
can say AC and BC.
Yes, you
since
can.
That's what the checklist says.
Correct.
Just
If the
remember,
checklist says it, that's what it
air
is.
conduction and bone conduction, that's what they stand for.
Right.
Forget, that's probably.
Because that could be a test question. What's next?
Nose and sinuses.
Okay, so we're going to inspect the nose and the sinuses. First, we're going to take a look at his nose, making sure there's no gross deformity, make sure it's midline. What's the words?
Nose is midline and without lesion or tenderness.
Okay, so actually it is inspection and palpation combined. So inspect first, and then you will actually palpate the nose, going down the ridge of the nose. Okay, and then the words are?
Nose is midline and without lesions or tenderness. And now you're gonna palpate and percuss the paranasal sinuses.
Okay, so when it comes to the sinuses, frontal, first things first, you want to get kind of underneath here, underneath the eyebrows, and you want to press up, palpating, and then down here in the maxillary. Feel that pressure? That's how you should palpate them. Then you're going to percuss. So the same areas you want to. Then?
No maxillary or frontal tenderness. They're gonna check the patency of nares.
Okay, so I want you to take your left index finger and cover your left nair and sniff. Sniff. Go ahead and change. Take a sniff. Okay.
Nasal passageways or patent.
Ooh, I don't have anything to smell with.
I do.
Here, I've got coffee.
No, not something that's not abrasive. Oh, see, not prepared. All right, so now we're gonna test right here on nerve 1. Alrighty, sir. I want you to do the same thing. I want you to take your left finger and cover your left nair, close your eyes, and tell me if you smell this. Can you smell it?
Yeah.
Okay, switch nostrils, and I want you to smell this for me. Close your eyes. Can you smell it?
Yeah.
Do they smell different?
Yeah.
Okay, cranial nerve 1 is intact.
They're gonna use the nasal speculum and inspect the septum, turbinates, and floor of nasal cavity.
So, we're using this bad boy again. Let's go. Okay, so when it comes to this, please put this underneath your arm. This is where I asked him, please look up a little bit to the ceiling. So can I go into the sniffing position? Where you go? I'm gonna go ahead and look into your nose. I want you to hold your breath when I tell you, okay? Bracing wise, we wanna brace like so. 2 points of contact for bracing, this and like so. That way I have, if he kind of move his head, I have control here, and I also have control of the actual speculum itself. Make sense? Okay. Okay. Hold your breath. Okay, and then I'm looking, and I'm gonna say,
Mucosa is pink and moist without lesions. septum is without perforations, unable to visualize superior turbinate, middle and inferior turbinates without discharge, edema, exudates, or polyps.
Oh, no, messed up myself. It came out.
You said that twice on, took one from each side.
One's on each side. What's next?
Mouth and throat. You're gonna inspect the lips, oropharyngeal mucosa, gingiva, stensons, and Watson ducts.
Okay, go ahead and, well, for here, we're gonna need whose bag is this?
This one.
It ain't that. All right, let's see. Let me grab this. We're gonna need to start getting the rest of this stuff ready.
Doing great, Chuck.
For the, for the.
How do you feel?
Can we just raise the bed up?
Yeah, I feel fine.
Like, press that forward
These
against-
these beds aren't raised up.
Oh, okay.
Yeah, they don't.
Sorry, I'm stepping in front of you guys so much.
Okay. So the light underneath. So I want you to do is I want you to go ahead and open your mouth, smile, and take your lips and then pull your lips up. Up and do on the bottom lips. Very good. So Stenson's ducts are at the what? The top or the bottom? Top. Okay. So go ahead and relax a little bit. You can go ahead and pull your top lips up. There we go. And then we're gonna look past the second molars. Cool. I see the opening there. Same thing on this side. By the second molar. Cool. Go ahead and say ah for me and lift up your tongue. Very good. Okay. What's next? That's the inspection.
Lips are pink, mucosa moist, without lesions, swelling, or discoloration, no stones or obstructions, and you're gonna inspect and press the teeth.
Okay. So these guys, the retainers, and say ah. Natural pitch, you would have them take them out. All right. So here you want to start from one molar. Come all the way down. Sorry, my bad. And then start from the other molar. Come all the way. And same thing on the bottom. Same thing on this side.
Now, normal teeth will have a click, 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 click.
Click, 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 yes.
Where with those retainers, that's a very smooth sound. But
Right.
we're listening for the click.
We're listening for the clicks.
Break the teeth.
Teeth are in good repair and non-tender.
Don't break them, but yeah, enough pressure. Okay, next.
Now you're gonna inspect tonsils and uvula.
Okay, so I want you to go ahead, look straight ahead, and I want you to say ah. So this is a little bit of a technique, right? You can use your tongue pressure because most people are not going to be able to see the tonsils or the uvula without having some type of tongue pressure. So say ah. What I like to do is like to have it halfway so they don't get like and then walk away. Say ah and just relax a little bit. Now say ah. His tongue is fighting me. Okay, I'm gonna leave you alone. Okay, and then you're gonna say
Tonsils are grade,
Two.
size, grade 2.
grade 2.
And equal with midline uvula, no exudates or lesions.
Okay, what's next?
Inspect tongue surface.
Interesting.
Visual inspection.
It just says
Could you
inspect
do
tongue
it
surface.
while you're
and-
doing it?
I know. I kind of feel like right. Doesn't this like this little? I know. Maybe we've been skipping around this whole time. We never thought about it. 'Cause I'm like,
So, the
So
one that
here,
I downloaded
if
off
you
the
are
IDMT
here, I'm
website
gonna
is
say
different
this.
than
I'm gonna
one.
call this audible. If you're already looking at the uvula and the tonsils, go ahead and test your cranial nerve test. So here, I would say that. Okay, say ah. Okay, your Roger foundation. Okay, I'm gonna gag you. Okay. Okay. I'm gonna jab you. Okay, now we say with cranial nerve check.
Uvula rise with
Uvula rises with phonation
and gag reflex.
and gag reflexes intact.
Question.
Yes.
For 41 and 42 is the tonsils, uvula, and 42 is the tongue surface. Can I say tonsils are grade size 2 and equal with midline uvula, no exudates or lesions, no discolorations or lesions on the tongue? Could I just combine that since I'm already looking in the mouth anyway?
Well, you can, but make sure your tongue that you're also doing the
Same
tongue.
tongue?
Yes,
Okay.
as well. Okay, I see that's why. No, because we still want them to move the tongue, don't we? to the sides for the tongue surfaces.
Yeah, that's.
But if I'm already in there and I have them doing it,
No, I mean for just inspecting the tongue. Are we okay with just?
Because it says,
Cause you're just like, hey, let me look at you. I'm checking the tongue surface, move to the left, move to the right before we have them do the whole. Are we okay with that?
What he's saying is, if you're inspecting
if
the
I'm already in
tonsils
the
and the
mouth and I
uvula,
have them do all of that.
Right. Yes.
Yeah.
Are we okay with combining that
Yes.
traditionally?
Yes.
Okay.
Inspection of the cranial nerve at the same time.
Yes,
as long
we're
as
good
you
with.
do
Okay,
those
we are
tests
good with that.
and
Okay.
Verbalize
And
it.
then end at the cranial nerve, and
Yes.
then go back and do the
It's
primary.
just when we start blending the
When we
different
start
things
blending stuff, and
together,
that's why I said we
they make
kind of like to
mistakes,
reset.
They get more used, so that's why
Okay.
it's so fragmented.
So let's keep it. All right. So for completeness sake, let's keep it separate. You're gonna talk about that. Take a pause beat. Talk about the inspection of the tongue. Okay. So no discoloration of lesions in the tongue, and I would rather you guys take a look at the uvula, right, and do all that, and then say, okay, now I'm gonna inspecting the tongue. At least let us know, and then just open your mouth, say, move your tongue a little bit to the left, a little bit to the right. If this is some of the surface on this side as well, that makes sure you're getting everything. So then no discoloration of lesions on the tongue. Then have them. Once you've done that, you've rise inflation gap reflexes, and now we're going to perform the bimanual exam.
What about 43, the cranial nerve?
We already did that.
and the cranial nerve 9 and 10.
You did me a favor, Wells. Okay. I should have set this up. Give me a 2x2. No 2x2s. No 2x2s. Check that over there for a 2x2. There we go. You got some over there?
Yes.
Okay, so here you're gonna need your gloves, and here you're gonna need a fresh 2x2. Actually, let me get another one. I don't need that yet. Just crack it open for me. Perfect. Just crack it open. Okay. So, by manual exam, we're gonna palpate the lips, the buccal surface, buccal mucosa, the gingiva, and the tongue. So the lips. You want to keep one hand inside the patient's mouth at all times, okay? Don't you, hey guys, come focus. We can ask these questions afterwards, right? Because it's important. Make sure you keep one hand inside the mouth. You're gonna use the other on the outside to palpate for masses. Don't be going back and forth switching, because now you're taking that person's, spit and everything like that, saliva, and then putting it all over the place. Keep one hand inside the mouth as much as possible, okay?
Clean hand, dirty. Clean hand, dirty.
The clean hand and the dirty hand. So, I'm gonna say and then you wanna start, and you wanna start with the lips. I kinda go up here and start, and I just go all the way around in a complete circle. And I'm mashing these tissues. And I know it looks crazy, but we're looking for any masses, right? And I have to just keep my hand all steady, and I'll turn around here. And just keep one in there. Okay, then say Then you wanna do the gingiva. So palpating all that on the outsides and on the insides. Like that. Then go all the way up. And we will be looking to see if you're going all the way. And then finish off here. Okay, so then that's our buccal, and then that's our lips, and then what's next? Okay, and then the tongue. So this is where your 2x2 comes in handy. You're gonna take your 2x2 and fold it out. All right, this part's okay. I'm right-handed, so go ahead and say, stick out your tongue. Grab it, wrap a little bit, and then you want to take your fingers. And remember, this is how I caught tongue cancer or oral cancer before. You just want to go, move it to the side, palpate all the way back there, and then here I think it's okay for you to switch hands and move it to the side. Palpate, and then we do what's called the squeeze. Keep your tongue out, and then we're gonna. I know that doesn't feel comfortable. All the way as far as you can. Palpate the tongue, kind of like milking it. Okay.
Alright, no edema, masses, or lesions.
No edema, masses, or lesions. So from this point on, everything you use from the mouth, you should be done with it. So fold it up, slice it, take your tongue blade and everything, and throw it on the floor. That way you know you've already used it, okay? Because if you have to go back and do something again, and you touch those same gloves, whatever, then that's bad juju, right? Because now it's like something's been all over the place. Okay.
Onto the neck, you're gonna inspect the skin of the neck.
Okay, so once again, look at the neck. Look at the here. Okay.
No lesions, swelling, discolorations, and most
Musculature?
Musculature is symmetrical.
Okay, so no lesions, swelling, discoloration, and musculature is symmetrical. Okay, then we're gonna look at what next?
Inspect and palpate for trachea.
The trachea. Okay, look at the trachea. Inspecting. Okay, we're gonna say what?
Trachea is midline and mobile.
Okay, so actually we are gonna inspect and then we're gonna move. So see that? It's mobile. Okay, so I'll inspect, take a look, and then move left to right, and then say the words again.
Trachea is midline and mobile.
Trachea is midline and mobile. What's next?
Inspect and palpate thyroid gland.
Okay, this is where we see people go off the rails here. So if you're not tall enough to get to your patient, say you have a really tall patient, go ahead and use a stool. They're about the same height. You just come around, make sure you're from the back. Take a look. Okay. I feel his Adam's apple. That's his cartilage. Okay, so we should be here. So I already know I should be in mostly relatively position. For males, it's easy because I'm kind of looking for Adam's apple, our cartilage here when we do our crikes, some of the rings, and then right as soon as I pass the rings, I'm gonna come like 1 to 2 down and then move over. And then I should be able to feel it. So I want you to, there we go. I want you to look to your left knee, gather some saliva, and then you're gonna push this way and then palpate this way. You see as I'm pushing hit this way with my right hand and swallow. And I'm feeling for any nodules, any lumps, any bumps if it's enlarged. And then look to your right knee, I'm gonna displace, and I'm gonna palpate. It kind of turn your head down a little bit. There you go, and swallow. Okay, and
Thyroid is normal size, shape, and consistency without nodules or tenderness.
okay. Any questions on that? So wherever you're palpating that side, you should be displacing to that side. So look down to the left knee, push with your right hand to the left side, and then palpate on that side. Look to the right knee, push with your left hand, and palpate with the right side, okay?
And you're gonna feel the thyroid?
Yeah, you're gonna feel the thyroid? You never felt the thyroid? Listen, so I'm just gonna tell you now, right? So find your trachea, everything midline, move just laterally, and then feel for that squishiness.
How far?
Some people's will be high. When you guys get way out here, right, this is the musculature. So where automatically you know you're too far. Feel that trachea, windpipe, come down, and then just come lateral to it. And then it's gonna be a touch feel. That's why we use the tips of our fingertips so we can kind of tell the difference. And you can just kind of walk it down, walk it down, walk it down, walk it down, walk it down. Okay, this is squishy. This is squishy to me versus up here. So this is where my thyroid is. And I can just kind of tell like, okay, yep, thyroid. Remember we talked about that base of the neck, right? So base of his neck is around here. So his thyroid shouldn't be that much farther up. If you know you're way up here in the Adam's apple, you're way too far, right? Oh, I feel something. This is the tonsils. No, come down. Use your anatomical locations. Come lateral.
Right beneath the Adam's apple?
Not right beneath it. This is Adam's apple right here. Right here. That's not it. So Adam's apple, cartilage rings, 1, 2. Then I just come over here. And then you can use your fingers. It's a touch feeling. Don't worry, you'll get it. Sure. Do the cricotid cartilage. Oh, I'm sorry, highway. Adam's apple, cricotid cartilage. Boom, 1 to 2 rings down, and then come to the sides. And then now I should be able to feel it. Now this is a great example of a thyroid. Everybody's size is gonna be different, right? But once you get past the Adam's apple, past the cartilage where we would crike, 1, 2 rings down, come over, you should start feeling the thyroid.
There's an even bigger model too.
Yes. That's the Adam's apple. That's the cartilage. 1, 2 rings down, move over, thyroid. It's a touch thing. It's a touch sense. Use the fat pads of your fingers. Some people are gonna have really big ones. Some people are gonna just be normal size. It might be a little bit smaller than others, but just take your time. Like right where you're at. No, that's okay. You gotta be lower, okay? Because you were like up here, so that's too far.
So when we look down at whichever knee we're looking at, that's the side that we're palpating, whichever side they look
The
at.
side that you're looking at is the side you're palpating. So if you're looking, they have them look at the left knee. You should be palpating the left thyroid nodule. Well, not nodule, the left thyroid lobe, excuse me.
Yeah.
As I was.
So just to clarify, so you have your SCM right here, right? Your sternum sternocleidomastoid muscle. When you turn and look down slightly, you relax that muscle. So it's no longer tense. There's no longer a natural tension on there anymore. So it makes it easier to palpate through it. So that's why we're palpating on the side that we're looking and bending or flexing slightly. Does that make sense?
Okay.
All the words make sense.
Yeah.
All the
A lot of
words
people
make
struggle with
sense.
this. It's okay. It takes some time. Now, what's next?
Now you're gonna palpate for all them lymph nodes on the neck and head.
All right, lymph nodes. Okay, here we
You
go.
wanna pronounce all of them.
Okay, so how many fingers? At least
2.
2 and 3. So right, index and middle. So preauricular is before the ears. Preauricular, postauricular, occipital. Don't be up here. Be down here for occipital, right? Then we want tonsillar. When you're looking at the tonsillar, look at the angle of the jaw. His is here, so you should be right up underneath here. Tonsillar, submandibular, submental. When you feel underneath your chin, there's like a nice little recessed area that's just gonna give after you get past the chin bone, after the chin, and then that's where you're gonna feel where those lymph nodes are. Okay, then you're gonna come, and then there's posterior cervical. I should have had it shut off. But posterior cervical, anterior cervical, all right? And then deep, you might not feel, but for me, I tell everybody pull the SEMs forward a little bit and go a little deeper, all right? And then here is our supraclavicular spots, where the SEM comes with the collarbone and makes that angle. This is where you're looking at, right up in here. Pre, post, occipital, submandibular, I'm sorry, no, my gosh. Subtonsillar, tonsillar, submandibular, submental, posterior cervical, anterior cervical, deep cervical is going to be kind of like underneath the SEMs, so you have to pull it, but most of the time you're not going to feel anything there. Right? Supraclavicular, right here at the angle where the collarbone meets the SEM, right off of it.
You just say it while you're going over.
Yep, say them as you're going. That way we know what you're talking about and you're not just touching stuff, right? Any questions on that?
Sorry, can you distinguish between the posterior, anterior, and cervical one more time?
Yes. Posterior cervical, we're gonna be going down in this direction, right? So, all right here, so you can see. Posterior cervical, we're going down here. Anterior cervical is kind of like in front of the SEM. You're coming down. This is SEM, so you're coming down this way, right? And then deep cervical, you shouldn't be able to feel anything, but you want to try to pull the SEMs or get deep underneath those. So you're kind of doing like a snatch motion,
Okay.
and then going in. That's why I was always taught to do like a snatch motion to get underneath deep, okay, and go all the way down. Okay. What's next?
And then you say no.
No lymphadenopathy, bilaterally, right?
It doesn't have
Don't say no.
Okay, so no lymphadenopathy. If you say bilaterally on everything, you're not wrong. That way, therefore, you don't miss anything. We've had a couple of students who will say bilateral, like no bilateral on the spine. We're like, okay, we're on the spine, but hey, we're not going to dock you for saying bilaterally. If you don't say bilaterally and bilaterally is listed, we will dock you. Right, Rex? Yeah.
Yeah.
Okay.
Alright, next is test active range of motion of neck. Flexion, extension, lateral bending.
All right, sir. So go to your neutral position. I want you to go ahead and take a look up at the ceiling. Look down, take your chin to your chest, come back to your neutral position. I want you to rotate your head to the left, rotate your head to the right, come back to your neutral position, take your left ear, go down to your left shoulder, and then right ear down the right shoulder. Very good. Come back to your neutral position, and
Full active range of motion without pain.
Now, a quick point, much like when we're doing range of motion of the spine, we do want to actually look at our patient too. So when you're telling them that like, turn to the right, you are not fully moving to the right, you're keeping your eye on your patient. Okay, so as you're doing all the different motions, looking at the patient, because that's the point. You want to see they have full range of motion,
yes.
equal in both directions.
You have to
Don't
do it
look
with
like
them?
Well, you can just look up at the ceiling. I can do it so that I can demonstrate with that motion I'm trying to tell you guys how to do. So up, down,
Just sound
good,
look
left.
all the way up, look all the way to your right, look all the way to your left,
Right.
look all the way to him, down to the chin of your chest, but you're still looking at them.
By the time we get the whole man, you guys will know what the deal is, so you won't have to do that. Okay, just tell them look up at the ceiling, look down, look left, look right, left ear to left shoulder, right ear to right shoulder. Okay. And then,
Strength testing, rotation, and shoulder shrug.
all right. Go ahead and press against my hand. I want you to rotate into my hand, sorry. Rotate into my hand, rotate into my hand, and then lift them against my, very good.
Cranial nerve number 11 intact.
I think that's it. Easy peasy. Okay, Rex, come through with corrections. What was I skipping out on? No, I skipped on something. I felt like no, I skipped on something.
I made the corrections as we went.
That's
Just
something else.
It's more like tidbits. I didn't see anything wrong. They're just common things that I see go awry.
Yes.
Just don't ever forget you have to look at your patient. Don't ever forget you need to have safety braces. 2 points of contact for both looking in the nose and looking in the ears. When you palpate the mouth, your bimanual exam. Bimanual, 2 hands, 5. You need to have 1 hand in, 1 hand out. I'll see people just do this weird finger sweep throughout the whole thing, and like, nope. So just don't phone it in. Do it right every time. You practice that way, you'll do it right for the head to toe.
Walker, keep me honest.
I don't really have anything to add to that.
Oh, shocking.
Just techniqueisms, but we try to stray away from that. So
Mhm.
what he taught you is what you're going to do for it.
Yes. So if there's any questions that come up, the way I taught you is the way we're gonna go, and we are all pretty much 98% each, all on the same line.